welcome to another lecture, and today we'll discuss something about respiratory failure in pediatric population. So here we begin with the lecture of respiratory failure in pediatric population. So acute respiratory failure is one of the most common emergency that we see in children, and it is due to inability to provide oxygen along with removal of carbon dioxide at the rate at which the body demands. Now, what is the definition of respiratory failure? So definition of respiratory failure is that there is PaO2. PaO2 is less than 60 millimeter of mercury at room air. Mind you, at room air, it is at room air, not at O2. You are giving O2. So that is less than 60 millimeter of mercury, or PCO2 more than 50 millimeter of mercury. So PaO2 less than 60 millimeter of mercury, or PaCO2 more than 50 millimeter of mercury, or an acute increase in PCO2 of more than 10 to 15 millimeter of mercury associated with acidosis. So if this criteria is fulfilled, then we call the patient as, we call it as respiratory failure. And chronic respiratory failure is defined as a condition requiring O2 therapy in any form, even at home. Now, where would you, give a patient O2 ventilator or BiPAP at home? So it is usually associated with conditions like spinomuscular atrophy or GBS, where there is neurogenic involvement and progressive failure where there is there, and or usually this interstitial lung disease do not occur in children because it takes time to develop. But in conditions like bronchopulmonary dysplasia or SMA, we have to give the patient O2 therapy at home. And this is associated with normal pH because this respiratory acidosis is, balanced out by metabolic alkalosis. So what happens is that PaCO2 is increased, but the total pH is normal because it has been, figured out and improved by kidney, and it will lead to, compensation by kidney. And acute on chronic respiratory failure is, a patient with chronic respiratory failure having any abnormality or any disease or some acute exacerbation of the condition, which leads to patient having failure of respiratory failure in a chronic patient. Now, what are the types of respiratory failure? This is very important, and has been asked again and again and again. So type 1 respiratory failure is where there is decrease in PO2 and there is decrease in PCO2. Okay, this is seen in 5P: 1, 2, 3, 4, and 5. Okay, pneumonia, pulmonary edema, pneumothorax, pulmonary embolism, and PAH, pulmonary artery hypertension. So these all are types of type 1 respiratory failure, and one of the two more common are cyanotic CHD and ARDS, adult ARDS, or non-neonatal ARDS, which has been, been very much in the news after COVID. So in COVID, what was happening? This ARDS was happening in patients of influenza, in patients of swine flu, in patients of bird flu. The cause of death always has been ARDS and MODS, multi-organ dysfunction syndrome. And in that, both PO2 and PCO2 are decreased, and there is failure of lung oxygenation to meet the metabolic demand of the body. So type 1 hypoxemic respiratory failure has decrease in PCO2 and PO2. In type 2, there is decrease in PO2, but there is carbon dioxide retention, and it usually occurs due to neuromuscular failure like poliomyelitis, or in Guillain-Barré, GBS syndrome. So this occurs. Then in drug overdose, like morphine and opioids, there might be severe asthma where there is severe bronchospasm, where there is carbon dioxide retention and the oxygenation is incomplete. Then muscle disorder or spinal damage. Even in accidents or spinal damage, what happens is the nervation, the innervation of the respiratory muscles is involved. And obesity, hypoventilation syndrome, which we know as Pickwickian syndrome or obstructive sleep apnea. So this is obesity, hypoventilation syndrome, also known as Pickwickian syndrome or obstructive sleep apnea. The other two types are, commonly asked, but they are not given in any book per se. But a lot of them have been classified. The type 3 is post-operative abnormality due to restricted mobility, and type 4 is underperfusion of respiratory muscles in case of shock. So these are the four types of respiratory failure seen in pediatric population. Now, in pediatric population, how will you define the etiology of respiratory failure? So either there is, abnormality of the pathway. Here there is abnormal pathway, or there is abnormality of the physiology. So if there is an abnormality of pathway or anatomy, and there is abnormality of the function of the physiology. So in cause of respiratory failure, as you know that the smallest area is subglottis in pediatric population, while it is glottis in adult population. So this subglottis is the smallest or the most narrow area in pediatric airway, and it gets enlarged. It might get inflamed in croup or laryngitis or abscesses, vascular rings, or enlarged lymph node compressing the subglottic area, or there might be presence of foreign body like peanuts. The most common foreign body that goes in the respiratory tract is peanuts, and the most common foreign body overall are the coins. Okay, so there might be tracheal stenosis or tracheal webs, or there might be, external compression to the lung like tension pneumothorax or pneumomediastinum, or any mediastinal mass that is pressing on the most common the mediastinal mass in pediatric population, it is non-Hodgkin's lymphoma. There might be abnormality in alveolar gas exchange, while like there is pulmonary hemorrhage, so the entire lung is filled with blood instead of air or surfactant. There might be pulmonary edema, meconium aspiration syndrome, pulmonary fibrosis, pulmonary embolism, atelectasis, and there might be ventilation perfusion mismatch. So in shunting, there is increased shunt or cardiac lesions where there is shunting off of the blood. What happens is the blood fails to oxygenate, and due to that, there is ventilation perfusion mismatch. In respiratory pump abnormality, we have diseases like Duchenne's and Becker's muscular dystrophy. Werdnig-Hoffmann is the other name of SMA1. And SMA1 is infantile in onset, and it occurs early and compared to the type 2, type 3. Demyelinating disease, Guillain-Barré, we know it has ascending paralysis, and it is, the respiratory failure is correlated with the bicep jerk deep tendon reflex, which has the same innervation as the diaphragm. There might be presence of neuromuscular junction abnormality like myasthenia gravis or medications, neuromuscular blockers, or there might be chest wall disorders where there is scoliosis or Juin syndrome. Juin syndrome is actually, constricting. There is a constricting power on there is constriction of the thorax, and the death or the prognosis is very poor, and gradually the patient worsens and worsens. In CNS causes, there might be traumatic brain injury, there might be CNS infection like meningitis or encephalitis, or increased intracranial pressure, increased ICP, which might lead to chain stocks breathing or a Biot's breathing depending upon the area of lesion, or there might be hypoxic ischemic encephalopathy due to birth injury. There might be drug overdose, like, drug overdose, commonly barbiturates, maternal barbiturates, or opioids. These may lead to, drug overdose or adverse effects of any disease. And systemic illness, again, systemic illness may cause hypoperfusion, and they may cause hypoperfusion to the muscles and hypoperfusion to the brain centers. Again, as you all know, the respiratory center is present in pre-Bötzinger complex inside the brain, in the medulla, and you do not forget it. There are apneustic center and there are pneumotaxic centers. Now, what are the causes of, according to the age? So in preterm infant, hyaline membrane disease or infantile RDS is very common. Congenital pneumonia, we have seen patients of congenital pneumonia where there is, a patch is present since birth in a child, and that lung has collapsed and consolidated. There might be sepsis, and bronchiolitis usually occurs in more than 2 months of age, and rarely even diseases like pertussis. Pertussis will lead, less than 2 months or less than 6 months. It causes apnea. So pertussis is also a common cause of respiratory failure in childhood. In newborn, if it is a full term, the child is full term, meconium aspiration is commonly seen, and there may be malfunctions like congenital diaphragmatic hernia or tracheoesophageal fistula, which causes excessive frothing, and that frothing causes it goes, if it is not cleared out, it goes into lung to cause aspiration pneumonitis. Now, there might be again nosocomial pneumonia and sepsis. Now, in infants from 1 to 12 months, sepsis is the most common cause of respiratory failure, and bronchiolitis is very commonly seen in this age, and the most common cause of RSV is bronchiolitis. Prevention of RSV is done by monoclonal antibody, which is named palivizumab. Palivizumab. But this is only used for prevention and not treatment. For treatment for bronchiolitis, you have to give adrenaline and 3% nebulization and O2 support. It is a viral disease and it will recover on its own. You just have to give supportive treatment and prevent respiratory failure from occurring. So you can give nebulization with 3% NaCl or adrenaline. There is no role of steroids. There is no role of SABA or LABA. In bronchiolitis, the only drugs that matter are 3% NaCl, adrenaline, and respiratory support with HHFNC or CPAP. Again, there might be circulatory arrest, and in school children, again, RSV is seen. And once they start, playing around, foreign body aspiration is very common. Inhalational injury, drowning, trauma, and accidents. Now, why are children more prone to respiratory failure compared to adults? So there is higher BMR. The child, see, many patients will come to UK. My child's head is warm. Why? Because there is increased metabolism, increased blood flow requirement, increased flow, and the metabolism is higher. That is why children eat and they do not get fat usually when they are younger. So there is higher BMR. There is decreased response, or there are decreased physiological response to hypercapnia and hypoxia. And sometimes what happens is there are, paradoxical reaction to hypoxemia, that it further suppresses the respiratory system. So sometimes even that happens. There is higher susceptibility to infection, and again, there is decreased immunity compared to adults. In newborn, if you see, the newborn have very limited immunity, and that is why sepsis is a very common cause of death in newborn. The bulk of respiratory muscle is lower, so early involvement and they get knocked out very fast. Again, in preterm, the lung immaturity is there, and they are obligate nasal breathers. If there is nasal blockage, then they tend to asphyxiate rather than mouth breathing. You might know that radius, the total area that airway covers, is directly inversely proportional to the fourth power of radius. So if this respiratory tract is obliterated by 4 mm, then what happens is the resistance increase by 16 times. So you have to see that the resistance of the airway is inversely related to the fourth power of radius. So what happens is that if the radius has decreased by so much, the cross-sectional area drastically decreases, and then what happens is that the flow decreases. That is why asthma may cause sudden onset bronchospasm or anaphylactic reaction. If there is there, then what happens is there is sudden collapse in pediatric population. Now, what are the clinical features? Here we can see that the child is irritable, agitated, and anxious. The child initially is irritable, then child goes lethargic, and finally the child becomes comatose due to carbon dioxide poisoning and hypoxemia. General examination, there might be flushing, there might be pallor, and pallor is commonly, these terms are called as ashen colored child, rakh or ash colored child. The child loses all the color, the pinkish color the child has, all the color is lost, and the child becomes ashen colored, and there is increased work of breathing. And what are the clinical features of increased work of breathing? There it is tachypnea, Now, how do we define tachypnea? Again, it is same definition, more than 60 per minute, more than 50 per minute, and more than 40 per minute. So in less than 1 month, it is, more than 60 per minute. In 2 months to 1 year, it is more than 50 per minute, and 1 year to 5 year, it is more than 40 per minute. So that is what we call it as tachypnea. If the respiratory rate is more than this limits, we call it as tachypnea. There is something known as tripod position, where the child sits like this and takes support. So the child which is sitting has two hips as one of the two supports of the tripod, and one support is from hand, which decreases the work of breathing. Grunting is an active effort to prevent the collapse of the airway, and it may be heard with a naked ear or it may be auscultated. There is nasal flaring due to involvement of the Allen-Nazi muscles. There is retractions of the ribs, and there may be paradoxical breathing. Initially, CVS responds with tachycardia, but later it may be turned as bradycardia. And or auscultation, you find a lot of sounds like stridor, creps, wheezing. Now, what is stridor? Stridor is usually due to upper airway obstruction, and it is a harsh, noisy inspiratory sound. And it usually suggests two things: either acute laryngotracheobronchitis or laryngitis, or there is presence of foreign body. So usually stridor is associated with croup or foreign body. And crackles or crepitations are heard. They are crackling sounds like a velcro sounds, and they are heard during inspiration. In pneumonia, you hear coarse crackles, while in pulmonary edema, you tend to hear fine crackles. Coarse crackles are, as they historically say, like a velcro, the sound of a velcro. That is coarse crackles, and it is associated with pneumonia, usually with lobar pneumonia. And wheezing is associated with lower airway obstruction, and it is usually an expiratory sound, but it may also be heard in inspiration along with expiration. And it is seen in bronchiolitis, and it is seen in asthma, it is seen in foreign body, it is seen in viral pneumonia, and it is seen with Walry, wheezing associated lower respiratory illness or Walry. So all these signs, all these are associated with wheezing sounds. And whoop is a specific high-pitched gasp followed by a loud bout of cough. And it is usually seen in pertussis, but absence of a whoop in pertussis is not a marker that pertussis is not there. Like pertussis may occur without the whoop, but it is historically been seen. Now, how do you correlate clinical features with the site of pathology? So nasal flaring, retraction, tachypnea, wheezing, stridor are associated when there is abnormality in lungs or the plumbing, the airway system. If there is respiratory control abnormality, we see different types of breathing like periodic breathing. We see chain stocks breathing. We see biodes breathing. So this different rhythm of breathing is seen. The rhythm of breathing changes, and all the different variants of breathing like Kussmaul's breathing and all that is seen. If chest walls and muscles are involved, then there might be paradoxical respirations. And it also, you can see that during inspiration, instead of the chest going, getting inflated, it will deflate. And it is usually seen with SMA or neuromuscular disorders. Now, these are the all-in-all clinical features like increasing accessory muscles, decrease in alertness, restlessness, apprehension, flaring of nares, then circumoral pallor, again ashen color faces. There might be cyanosis. There might be club fingers. Club fingers is usually seen in chronic abnormalities like bronchiectasis and cyanotic CHD. So clubbing of fingers is usually seen in chronic abnormalities. It is not seen in acute diseases. Cyanosis, Rales rhonchi wheezing, and intercostal, costal, sternal, and substernal retractions are seen depending upon the locations of the retraction. Now, what is the definition of PADS? So PADS is pediatric as acute respiratory respiratory distress syndrome. And you know the definition of respiratory distress syndrome, that it occurs within 1 week of known clinical insult, and the origin of the edema is not explained by cardiac failure or fluid overload. So if you have a patient of CHD, then the edema should not be explained due to CHD. Like, there is TOF. So in TOF, usually what you have, pulmonary oligemia. So in a patient of TOF, if you see pulmonary edema, then it is not explained by cardiac abnormalities. So it can be called as ARDS. So ARDS is actually non-cardiogenic pulmonary edema. And what happens is it occurs within 1 week of clinical insult. And how do we grade the severity of parts? So here, if the patient is on mask or positive pressure bilevel ventilation or CPAP more than 5 centimeter of water, so the PEEP or PEEP or peak end expiratory pressure of the CPAP is more than 5 centimeter of water, then only you can quantify the parts or the parts definition in non-invasive ventilation. In invasive ventilation, they have good definition, but in non-invasive ventilation, you have to have more than 5 centimeter of water of peak and expiratory pressure with PF ratio more than 300 and SF ratio less than 264. Okay, so this is PF and SF ratio. It is the PaO2 or SpO2 ratio, and PaO2 FiO2 ratio. PF ratio is PaO2 and FiO2 ratio. So PaO2 we measure from blood, PaO2 we measure from blood, and FiO2 is the amount of O2 in the inspired air. So if the patient is on room air, see this definition does not contain room air patient, but we'll take example that what is the FiO2 of room air. So it is 21%. If we inhale the room air, the total concentration of O2 is 21%. So in case of BiPAP, if you keep FiO2 of 100 and the PaO2 is also 100 of the patient, then the SF ratio is 100. Okay, so it is, the definition is 100 into PaO2 divided by FiO2, and SF ratio is 100 into SpO2 divided by FiO2. So that is SF ratio. Okay, so you have to remember that these two, if the values is less than 300 or if SF ratio is less than 264, then we will call it as pediatric ARDS. Quantification of the severity of ARDS can only be done in invasive mechanical ventilation, and it cannot be done in non-invasive ventilation. So in invasive mechanical ventilation, OI is oxygenation index and OSI is oxygen saturation index. So what is OI? OI is actually same as PF. It is 100 into PaO2 divided by FiO2 into mean arterial pressure. MAP into OI is actually OI. MAP into PF ratio is OI, and MAP into SI ratio is OSI. MAP is mean arterial pressure. So if the value of oxygenation index is less than 4, more than 4 and less than 8, then it is mild. Moderate is 8 to 16 and severe is more than 16. So this you have to quantify the patient on severity. So in patients of ARDS, you can calculate PF ratio or SF ratio or OI or OSI, and then you can grade the patient according to the severity of ARDS. Again, this is localizing signs. Now, what are the clinical features of mild, moderate, and severe ARDS? Okay, these are the clinical features of ARDS. So in a mild patient of ARDS, there is usually no hypoxia and mild hypoxia, but the clinical features are not there because there is mild hypoxia. So mild hypoxia manifests as flushed skin and headaches, but it does not have other clinical features, while moderate hypoxia will present with dyspnea, headache, dizziness, tachycardia, tingling, euphoria, and disorientation, while moderate hypercapnia will present with tachypnea, tachycardia, DTR are depressed, and confusion and delirium. As you know that hypercapnia is the stimulant for central chemoreceptors. Central chemoreceptors. So you have to remember that CO2 is the activation for central chemoreceptors, and severe hypoxia has cyanosis, visual impairment, loss of consciousness, seizures, and coma. And hypercapnia will have papillary edema and coma. Now, how do you assess a patient with, ARDS? So we have 5 criteria that what is the appearance. So in patient with distress, see, there are 5 guidelines like distress, what respiratory distress, there is respiratory failure, there is shock, there is metabolic involvement, and then finally is cardiac pulmonary failure. So this is the increasing level of severity. So in distress, the appearance is normal and work of breathing is increased while the color is normal. While in failure, the work of breathing is also abnormal. The child is breathing heavily, and color is normal because again the work of breathing can compensate the severity. While the appearance gets abnormal, the child gets lethargic and decreased intake is there. While in shock, the color also goes away, and in metabolic involvement, everything, work of breathing and color is normal, but when you do ABGA, you find acidosis. In cardiopulmonary failure, all 3 are abnormal. Okay. Now, ARDS, we know ARDS has 3 phases: exudative, fibropulmonary, and recovery phase. Exudative phase is the acute phase, and it lasts for 1 to 3 days, and it is the disease developing. Fibroproliferative is that gradually there is healing, but usually lung heals with fibrosis. So the area that is lost in damage heals by fibrosis, and then it never oxygenates throughout the lifetime of the patient. So in fibroproliferative space, the dead space is increased, and it lasts for 2 weeks where there is repair and all that starts to occur. And in recovery phase, the final improvement occurs. And as you know, what is the definition of ARDS? It is acute onset less than 7, non-cardiogenic pulmonary edema where left atrial hypertension is there with PaO2 FiO2 ratio less than 300 or less than 200 of acute. If it is less than 300, it is acute lung injury. And if it is less than 200, then it is acute respiratory distress syndrome. This is the Berlin definition. This is not the PADS definition. And this is for adults. This is not for pediatrics. For pediatrics, we saw the PADS definition. Now, what to do in patients with ARDS? So pulse oximetry, we have to do. Pulse oximetry is very important, and we have to do continuous pulse oximetry in the patient. Chest X-ray is to be done to see there are bilateral ground glass appearance may be seen. So white out lung, the lung which is usually black, the area is completely white out, the lung is completely white. ABGA should be done to see the metabolic acidosis which is associated with the patient and the measurement of PaO2 and TCO2. And a capnography is now available with many of the ventilators that we have, and it measures EtCO2 and tidal CO2, which helps for 2 reasons. One is that when you intubate the patient, if the ET tube goes into esophagus, then EtCO2 will show that there is no CO2 excretion present. And the second important usefulness of EtCO2 is it measures the effectiveness of ventilation. Means if the ventilation is getting adequately, if the ventilation air or the pressure you are giving is getting delivered adequately or not, and if the pulmonary circulation is intact, which causes the CO2 to come from the body to the lungs and excreted out to be measured by your device. Now, O2 administration is very important. There are 2 main types of O2. So one is flow devices. They can be divided in flow devices. So low flow device, and then there are high flow device. Now, what are low flow device? Low flow device are that when you keep them at their full strength, even then they cannot fulfill the lung demands. So that is low flow device include O2 cannula, O2 mask, O2 mask. And please remember that non-rebreathing mask is also a low flow device. It is not a high flow device, though it can give SpO2 as high as 90%. The FiO2 of the air is as high as 90 to 100% in NRBM. The flow of the NRBM cannot exceed to one beyond one limit, and due to that it is classified as a low flow device, while high flow device are high flow nasal cannula and CPAP devices. So these both are high flow devices, and you have to remember NRBM is a low flow device. Now, there is another system known as Venturi mask. This Venturi mask is a mask which has, a valve in which, and it is color coded valve, and it selects the flow that is present. Now, how to measure the total FiO2 delivered in a nasal cannula? You have to do 21 plus 3 into total flow of the O2 cannula. So consider that you are giving O2 cannula flow at 4 liter per minute. So you multiply into 3. So the total FiO2 that you are delivering is 21 plus 12. And that turns out to be 33% FiO2 delivered. If you give more than 10 liters in O2, see, the advantage of O2 cannula is the face remains open. So you can give feeding to the patient, you can easily put an RT tube, and the patient is comfortable, except the inside the nose there is some irritation, but overall the patient is comfortable compared to a mask where the face is blocked, and there is a lot of leakage present if the mask is not tight. So that is the difference between cannula and mask. And then there are non-rebreather mask and partial rebreather mask. Now, what are rebreather and partial rebreather masks? So what happens is that what happens is when we have an O2 mask, then we inhale and then we exhale. So what happens is that the air that we have exhaled, the air that we have exhaled stays inside the mask, and it can be breathed again. You can breathe that CO2 that you have expired, plus all the environmental air can also easily come into the mask. In partial or non-rebreather mask, there are two valves which have one-way flow. See, you can see what are the rebreather masks. They are the masks that you might have seen in COVID with that a bag which inflates and deflates. When the patient inhales, it deflates, and when the patient exhales, it inflates. So that valve is a one-way valve. So whatever the patient exhales, it goes out of the mask, and that pure O2 that comes from the O2 supply is directed via that one-way valve to you. So it may give SpO2 as high. SpO2 can be given as high as 90 to 100% from non-rebreather mask. Sorry, the FiO2, the flow or the FiO2 of the non-rebreather mask may be 90 to 100%, but the flow cannot be increase more than 15 or 20. Beyond that, it becomes useless because the flow cannot be taken in easily. So that is why it is a low flow device. If despite giving such low flow and high flow devices, the SpO2 is not improving, then you can give the patient to positive pressure ventilation like CPAP or BiPAP. BiPAP stands for bi-level positive airway pressure, and CPAP stands for continuous positive airway pressure. So when you give air with pressure, the air exchanges increase. So that is the main theorem behind CPAP and BiPAP. And positive pressure ventilation can be given by high flow nasal cannula, but it devours a huge amount of O2 flow every minute. And you can give CPAP, continuous positive airway pressure, and the presence of CPAP has revolutionized the treatment of ARDS, and CPAP is now routinely being given to the patients with ARDS and even neonatal RDS. After you give the ensure technique, you give surfactant, and after that you can extubate the patient to CPAP. And what does this CPAP do? This CPAP provides a continuous amount of positive pressure, which does not allow the trachea or the bronchus to collapse during expiration. In inspiration, when the flow is high, what happens is it expands, and in expiration, it might collapse. So this collapse is prevented by a presence of a continuous positive airway pressure, and thus CPAP is very beneficial in patients of ARDS. And BiPAP is a type of CPAP which has two pressures. So in inspiration, it has a different pressure. In expiration, it has a different pressure. While in CPAP, it maintains a single pressure throughout the cycle to prevent the collapse of the lungs. Again, mechanical ventilation is a very important technique, and it has been routinely used, and you might have seen in your wards that routinely patients are ventilated, and there are multiple modes like IFV, SIMV, and all that. We'll go that in detail in another lecture. And in mechanical ventilation, you can select the rate, you can select the FiO2, you can select the time for inspiration, you can select time for expiration, and everything you can set in the ventilator. So that is very beneficial in patients with severe respiratory failure. Okay, so here on the right side, you can see the FiO2 that are delivered by the different devices, like nasal cannula, 25% to 45% of FiO2 can be given. By face mask, you can give 35 to 60%. By NRBM, I told you that, if the flaps or the valves are present, it can give up to 80% FiO2 to 100% FiO2. And though it is a low flow device, you have to remember. And this word entrainment is what does entrainment mean is that if you have a mask, the environmental air comes inside the mask, so that is entrainment. In NRVM, entrainment is to the minimum, though it cannot be 100% eliminated. It is minimum compared to simple mask. And this is color coding of a Venturi mask, and according to the color code, different amounts of SpO2 can be delivered in the patients. Now, what are the indications of mechanical ventilation in pediatric population? Again, if there is progressive respiratory failure despite O2 therapy, or the patient's GCS is less than 8, less than 8, then you have to intubate. Respiratory arrest, if there is present, or the patient has significant acidosis, respiratory acidosis, or if there is impending cardiac arrest, or if the cardiac arrest has already happened, you have to go for mechanical ventilation. I guess that's all for today, guys. I hope you like the video and you learned something new today, and I'll see you in the next one.